Are we starting? Assalamualaikum and a very good morning. A warm welcome to all participants, dear colleagues, faculty member and students. Today we have gathered for an important purpose to reflect, we collaborate and work together towards a healthier, more sustainable population future for our communities. The course correction gathering is not just a meeting, it is a collective effort to understand challenges, share insights, and shape responsible decisions that will impact generations to come. Your presence shows commitment, your voices bring value, and your ideas will help guide the way forward. Thank you for joining us, for contributing your expertise, and for being part of the important national conversation. I welcome you all. Let's begin our journey with a meaningful change and with the recitation of Holy Quran.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. صدق الله العظيم.
Thank you very much. Today our chair was, due to some engagements, he cannot join us. Mr. Mustafa Kamal, he is a current federal minister for the Ministry of National Health Services Regulations and Coordination in Pakistan, a position he has held since March 7, 2025, a prominent politician associated with Muttahida Qawmi Movement, Pakistan. He played a key role in shaping national health policy under Prime Minister Shehbaz Sharif government. Overview of Mustafa Kamal is his current portfolio is as minister, and he oversees critical national health initiatives, including the formal launch of telemedicine services, polio education efforts, and boosting the pharmaceutical industry's export potential. He has emphasized that all the ministry action under his leadership will focus on making a positive impact. Due to some previous engagements, he cannot join us. Dr. Nadeem was the co-chair, and he is Federal Secretary, Ministry of Health, Education and Prevention, Professional Training, Islamabad. He was also Secretary of Health, Ministry of Health, and I would like to add that his father was also Secretary, Population Welfare. He has been BPS 21 officer of Pakistan Administrative Services. Currently holds the position of Secretary of National Health Services, Regulations and Coordinations. Throughout his career, he has worked in different capacity at various levels, such as districts, projects, and ministries, both at federal and provincial levels. He served as Provincial Secretary at the Higher Education Commission, Housing and Public Health Engineering Department, as well as Youth Affairs, Sports and Tourism Department in Punjab. Now I invite Ms. Grace Kelly as a chair. Grace.
Clark.
She was
Her name is Grace Clark.
Grace Clark. please come on stage. She was Dean of Sociology Department in FC College, and she also held a position at Fulbright Scholarship. Currently, she is teaching in Paris. Thank you, madam, for joining us as a chair. Please.
Thank you.
Thank you, of course.
Yeah, by the way, those who in my generation, Grace Kelly was a very, very famous Bollywood
Sorry.
personality.
I'm not.
And she is nothing less than her. I'm in the-
Now I invite Mr. Mehtab Karim. He is Professor Emeritus. He is social demographer with interest in population and health and migration issues in South Asia and Muslim majority countries. He has co-authored 3 books and has published over 60 research articles. He was a senior faculty member at Aga Khan University in the Department of Community Health Sciences for about 25 years. Besides, he has held appointments at universities and research institutes in USA and UK. And he has been president of PEP long before, and he is again our second time president for PEP. His current areas of teachings are demography, research method, data analysis, social and economic development. He will moderate the session. Now I invite Dr. Fareed Mittal. He is as a panelist. He is a distinguished scholar and seasoned professional who currently serves as the Vice President of the Population Association of Pakistan with the PhD in demography from a leading university. He has dedicated over 2 decades to researching population dynamics, health outcomes, and socio-economic development across South Asia. Prior to the tenure at PAP, Dr. Vidhat has held senior position at several research institutes where he led projects on fertility trends, migration patterns, and policy impact assessment. His expertise has been instrumental in shaping evidence-based population policies that address the challenges of rapid urbanization and aging population in Pakistan. Dr. Vidhat is also an active member of international forums, regularly presenting his findings at conferences and contributing to peer-reviewed journals. I would like to add he has also worked with the National Institute of Population Study in Pakistan Maternal Mortality Survey in 2006-7 also. In DHS, we worked on maternal deaths. And it was a Dr. Aisha Khan could not join, so I invite Dr. Imran Javed. He is deputy. He has joined in the Atar Hamid Khan Foundation in Rawalpindi. He leads a team on improving maternal and child health nutrition and disease prevention across underserved regions with a strong academic background and expertise. He has successfully implemented numerous programs that strengthen primary health systems and empower local community. He is frequent speaker at national and international forums and sustainable health solutions. I welcome you, sir. Now I invite Ms. Samin Siddiqui. She is a distinguished professor.
The Dr. Samin Siddiqui.
Dr. Samin Siddiqui, professor and former chairman at the Department of Community Health Sciences at Aga Khan University. She, for her primary and work at public health. Ms. Dr. Samin.
मुझे भी बहुत सारे लोग
Sorry for misinformation. Now I give the floor to Dr. Mehtab Karim.
Thank you very much, Dr. Asha. I welcome this for people coming from Karachi. It's a cold evening, cold morning, and I think it's also a lot of poor attitude of our several people, unfortunately, they couldn't make it. We had a different panel. It was a cross section of people working in social scientists and physicians. We had set up, unfortunately, this last night, I've been getting calls, at least from 3 persons, and they said, "Oh, sorry, you cannot come." The minister, he said, "Well, they have to go to the cabinet meeting at 11. And I had to write his speech. I wasted 2 hours doing that. Anyways, but he said it's not his fault. And chair, the secretary of education, he had agreed and then he never responded. Tried to call him, no answer. Dr. Zeba Sattar was supposed to be the co-chair and she had been too busy, too many commitments. She informs she is unable to come. I tried to get 2 very senior persons who are members of to come and speak on, because they have done quite a bit of work on family planning in Pakistan. Unfortunately, they also regret this. So I thought that we always have, in the past, we always we used to go to USAID, now we go to IMF whenever we need any help. So here we have Professor Clark. She's here to chair the meeting. Thank you very much, Professor Clark, Ms. Clark. She has been here in Pakistan for many years. She used to head the US Education Foundation. They used to give a lot of scholarships to Pakistani young people to go and do PhD and masters in America. And many of them have gone back, by the way, after serving here for 2 years or so. But it's unfortunate that Pakistan doesn't retain many trained people. There are not enough opportunities, I believe, for them.
The doctors of England.
There are some others. There are 3 persons sitting here. Dr. Farid Mithat. He's the only one who went for PhD from the Aga Khan University department, who is back in Pakistan. There are 6 others who were sent for PhD, and 3 of them did PhD in demography, and they didn't come back. One stayed back in Australia and 2 in America. We have to create an atmosphere in Pakistan like Australia and America. But we have anyway, so when we have a panel of, and we have one of my former students, Dr. Asha Khan, who was supposed to be here. She not regretted, she has sent someone who perhaps knows quite a bit what they are doing in the field. Dr. Farid Mithat has been a colleague, as a matter of fact. He was a very young man. I was middle age in 1985 when he joined Aga Khan University. And if I'm not mistaken, I pursued him to study population dynamics and even for, Columbia and then to Hopkins to do his PhD in population dynamics, public health. And of course, we have Dr. Samin Siddiqui, a great admirer of his. I've known him for many years. He was with the Ministry of Health. Then he moved on to WHO, Emerald region, and then as the chairman and professor at Aga Khan University in Karachi. And if I'm not mistaken, he has been heading a task force developing a new health and population policy for the government of Pakistan. I think he has submitted the report, if I recall it correctly. And so he is here to talk about how things can move. So we have a good panel, fortunately. Unfortunately, that there are not many listeners. There are, as I say that the population of demographer is shrinking and population of the country is increasing here. audience is shrinking, but still the population is increasing. Let's see how we go forward. So I have, I like it to be more like a round table, what we call, so that everybody gets an opportunity to talk after presentation. So first of all, I'd like to invite Dr. Farid Millat, who has a substantial experience and I think genuine critique of Pakistan's family planning program. Let's listen to him, what he has to say, and then we will move on. Thank you, Dr. Farid.
Oh, this is better than what I have heard before. Bismillahirrahmanirrahim. Assalamu alaikum. I think the main idea of the conference was in the beginning to look for course correction. We have been talking about course correction. What is course correction? And we talk and talk. So I think I would like to start working finally, because this is something which I would like to remind you. 72 years, 7 censuses, Pakistan's international population growth has never ever come down below 2.3. 2.3 is one of the 4 largest, I think, in the world. This is our population increasing, doubled twice in 22 years, doubled 26 years later, doubled twice, and then the thrice, like I think, is coming in 2027. जब पाकिस्तान 80 साल का हो जाएगा उस वक्त उसकी जो आबादी होगी वो इनिशियल आबादी की 8 गुना होगी, 8 टाइम्स। ये जो है ना प्रोजेक्शंस हैं जो कि बेस्ड ऑन लाइक 2.25 is the highest, 1.5 is the lowest. I don't think that looking at our history, we probably are not going to go below 2.25. The highest is that, and this is not 2050. 2047, we will be 405. I will not be here. But I'm saying that I think this is my feeling that the current affairs are like this, it's not far away from here. So 405 is a large number. But then we used to say that even 100 million is a large number, 200 million is a large number. So this is our projection. And what is demographic transition? That once you start from a high birth rate and high death rate, then the death rate goes down, birth rate slowly comes down, and then they become equal again, as similar again, and population starts increasing. We're nowhere close to that phase. Nowhere. Absolutely. This is the reason. ये हमारा नामाय अमाल होता है, DHS. We say a lot of things during the year and during the 4, 5, 10 years. बड़े हम दावे करते हैं, बड़ी अच्छी अच्छी रिपोर्टें आती हैं, टॉक बहुत होती है। अभी भी एक टॉक हुई थी ना, बहुत बड़ी सी टॉक इस्लामाबाद में पॉपुलेशन के ऊपर, पहले भी हुई थी। ये नामा अमाल आता है, आपको बताते हैं कि आपका MCPR मॉडर्न कैपेसिटी डेवलपमेंट रेट has been stuck since 2007. The only increase, reasonable significant increase, was between 1991 and 2007, and there was only one reason for that. This is how we use, our population uses contraceptives. So you can see the female sterilization is increasing. The median parity at sterilization is 4.5%, according to 2007. Second increase has been in condom. Easily available, and people know how to use it. But the failure rate is 18 to 20%. Pakistan, more discontinuation between is very, very high. I think it's probably not very effective. So maybe injectables, you can see injectables fill an ILD. Implant for the pushing, the high 0. All of them less than 3%. जब आप कहते हैं कि 25% है हमारी मॉडर्न कैपेसिटी रेट, तो उसका ये है कि उसमें से 9% कंडोम में 99% फीमेल स्टेरिलाइजेशन है, बाकी 9% जो है ना, 6% वो है आपकी उससे। Source of modern method, I think it should be remembered. And private sector provides condoms and pills, sometimes injections. NGOs जो हमारी बहुत ज़्यादा active हैं, बहुत famous हैं, visible हैं, they contribute only 15%. Lady health workers are the key people who actually are doing it in the rural areas. They still, contribute 9%. The program has been, like not as good as it used to be. Government health facilities usually provide IUDs and table ligations, 34%. So this is basically the source of last method they use. This is something I'd like to show you. आज रेशो क्या होता है, जैसे रेशो ये आपको बता रहा होता है कि ये कितने लाइकली है किसी खातून का एक मॉडर्न मेथड यूज कर, जैसे फर्स्ट लाइन है ना, एनी मॉडर्न मेथड। ये वो खवातीन हैं जिनके घर एक LHW ने लास्ट 1 ईयर में 1 या ज्यादा विजिट्स की थी। उन खवातीन की लाइकलीहुड ऑफ यूजिंग एनी मॉडर्न मेथड वाज ऑलमोस्ट 2 टाइम्स मोर देन जिनके घर किसी LHW ने विजिट नहीं किया। अब आप उनसे पूछेंगे पैरिटी का भी इफेक्ट होता है, एज का भी होता है। वी हैव एडजस्टेड फॉर दैट, एज पैरिटी एंड वेल्थ कंट्रोल। सो बेसिकली दैट्स the main thing that see there are a lot of causes, and even natural methods. Women who are there are significant. Women who were visited by LHW were more likely to use even natural methods also. Another thing, previous 1990 में जो secondary plus खवातीन थी, they were about 3 times more likely to use a modern contraceptive compared to those who have less than metric education. Okay, basically no schooling. This is again adjusted ratio for age, parity, wealth quintile, and urban rural residents. Okay, 1990 with 2.778, almost 3 times. It came down significantly to 1.44 in 2006. I think it was due to the LHWs. Other reason, of course, because the LHWs probably had a contribution. 2017 में बहुत ज़्यादा change नहीं आया, same रहा basically. It's still, the difference is like, that 3 से जो है वो 1.5 है. ये वो है कि जी urban लोग जो खवातीन होती हैं, they are always more likely to use contraceptive, modern contraceptive, right? So in 1990 they were 2 times more likely to use contraceptives than the rural खवातीन. And after adjusting for age, parity, wealth quintile, and schooling education, it came down to 1.4 in PDHS 2006, significantly lower than 2.04. Okay. Again, I think there's lots of things happening in rural areas. LHW were one of them. अब ये बात आती है कि कभी हमारी जो यूथ पॉपुलेशन है वो एक्चुअली क्या, मतलब क्यों डिविडेंड नहीं है, क्योंकि बाकी सारे कंट्रीज जो हैं उन्होंने तो बेसिकली अचीव किया है ना अपना डेमोग्राफिक डिविडेंड। उसके रीजन रहा ये 70%, almost 60% male and female actually average कर लें, they have less than metric education. Then this is the like 33% and 25% who have above metric but less than graduate. Only about 12% men and women have education of graduate and above, diploma, everything. तो ये दिमाग है कि डिविडेंड आपका कहाँ लगेगा, किस काम आएगा। 4 रीजंस हैं पाकिस्तान के मेरे ख्याल में, ये शुरू से है और अब तक हाफ baked interventions. We really don't seriously invest in populations. Lack of evidence-based planning. आपको पता है DHS ने 4 में उनका कितनी कंट्रीब्यूशन हुई है प्लानिंग के अंदर। फिर प्लानिंग हमारे होती क्या है, पॉलिसी आ जाती है, उस पर मिनिस्टर के साइन होते हैं, वो इम्प्लीमेंट तो नहीं होती। Too much donor dependence. That's really one of the biggest hurdle in our development. And lack of financial commitment. कौन जाता है उसमें पॉपुलेशन में, जो सबसे निकम्मा असेंबली का मेंबर होता है उसको पॉपुलेशन मिनिस्टर बनाया जाता है, जो सबसे जो ना अनकनेक्टेड होता है उसको कंट्री बनाया जाता है। कैसे बांग्लादेश ने किया, वेरी वेरी स्ट्रॉन्ग पॉलिटिकल विल, जितना भी टर्माइल आया पॉपुलेशन के साथ उनका कमिटमेंट था, कम्युनिटी बेस्ड डिस्ट्रीब्यूशन वाज एक्सीलेंट, कल्चरल अलाइनमेंट वाज एक्सीलेंट। आप में से एक बार लोगों ने सुना होगा मेंस्ट्रुअल रेगुलेशन का जो वहां कैसे उन्होंने उसको मतलब अलाइन किया। आई डोंट हैव टाइम टू गो इनटू दैट। Excellent communication campaigns and integration into PSC, everybody could get, you go into health facility, you can फैमिली प्लानिंग फैसिलिटी। कोर्स करेक्शन के लिए हमारे पास क्या प्रॉब्लम है? कंट्रोलिंग द करप्शन सबसे बेसिक, then difficult decisions which we never made, we should have made long time there. We haven't set our priorities, and of course there is no financial justice and equity. एक करप्शन की फॉर्म जो है ना वो एक सिर्फ फाइनेंशियल लीकेज नहीं है, जो कि बहुत ज्यादा है हमारे मुल्क में. There are theft of supplies and equipment. There are non-use of supplies. The village-based family planning workers used to throw away the supplies they got. And deliberate lack of oversight. आपके अपने बंदे लगे हैं, कोई देखने वाला है नहीं, सुपरविजन है नहीं. Absenteeism with ghost workers. मुझे पता है, आपको पता है, सबको पता है. And distractions from the job at hand. Even if the Sakti Sahib is sitting there on his desk, he is not doing his job. He is doing something else. Whatever is right now the priority. ये difficult decision है जो हमने कभी नहीं किए. Make family planning a health service. It's not integration. It's not about bringing the VVFPWs into CWs. It's not like bringing the FWCs into rural health centers. It's actually making family planning health services because that's what it is. Okay, we haven't done that. Redirecting financing from showcase projects to public health interventions. ये तो खैर नहीं हो सकता पाकिस्तान में. And finally, good governance and accountability. I think the worst governance and lack of accountability is in the population sector. So you have to stop and just thank you.
Dr. Farid. Now let's go to Dr. Hamid Khan Foundation's project in different cities of Pakistan. I'm so glad that this foundation is there. Dr. Aisha Khan, who is the daughter of Dr. Hamid Khan, very well known social scientist, who did miracles. It's a project in Pomila in East Pakistan, then he moved to Pakistan. He established this Orangi pilot project in Karachi, and I had quite a bit of interaction with him when in 1984 we decided at Aga Khan University, I just ran Department of Community Sciences, that we take our students to spend a day in one of the Kachi Abadis of Karachi, and Orangi was then was perhaps the largest Kachi Abadi as far as settlement. So we wanted to establish a health facility there, health program in the community. And he told me, Dr. Sir, the most important thing you can do, convince our people to do family planning. Coming from a person who was, a former bureaucrat at ICS, and I was stunned that, okay, he's talking about it. And yes, we implemented a family planning program with support from Orangi Pilot Project. And within 3 years, contraceptive use rate, and Dr. Farid was then working also with us as a young doctor. And when we got the evaluation done, contraceptive prevalence rate had gone by then, I think, from almost 1 or 2% to, I think, about 20%, if I recall it correctly. And I'm glad that his legacy has been transferred, to Dr. Aisha Khan. Unfortunately, she couldn't be here, but we have a representative from Dr. Hamid Khan Foundation to speak about how they are implementing the program, especially family planning and integrating it with primary health care. Please.
Yes, thank you very much, sir. I would try my level best to fulfill the gap of Dr. Aisha Khan, although she is not here, but I will try to explain our program and that what we achieved in the field. मैं डॉक्टर फरीद की जो प्रेजेंटेशन थी उसमें से कुछ पॉइंट्स को बेस बनाऊंगा. डेफिनेटली इन्होंने बहुत अच्छे पॉइंट्स रेज किए और फिर सर आपने डॉक्टर हमीद खान का जिक्र किया, तो मैं उनका कॉन्टेक्स्ट जरूर बताना चाहूंगा कि उन्होंने जो काम किया उसमें विल थी. लॉट ऑफ विल, उन्होंने बड़ी डेडिकेशन के साथ काम किया और हमारे लिए बेसिस बना दी. ओके, thank you. I will explain again that Dr. Akhtar Hamid Khan, we are continuing the legacy of Dr. Akhtar Hamid Khan, who is the great social scientist for Pakistan. Not for Pakistan, he also introduced Pakistan in the world, that how we can contextualize the development work for the community, and we are also implementing the same things here in Rawalpindi, Islamabad, Karachi, and other areas of Pakistan. Our program based on the contextualization. First of all, whenever any organization or any institution or even the government departments are planning and implementing a project, they are heavily miss the component of participation of community. So first of all, we introduce the community participation. That is the basic and grassroots terms of our program. And the second one, we contextualize the service delivery of family planning. In government sectors, mostly you saw the terms, you hear the terms of LHW, lady health worker. Although she is highly qualified and उसके पास एक्सपीरियंस भी ज्यादा है, उसको गवर्नमेंट सैलरीज मोर सैलरीज दे रही हैं और उसके ऊपर लोड भी बहुत ज्यादा कर दिया गया है. तो क्या आप व्हाट यू पीपल थिंक दैट अ लेडी हु इज वर्किंग फ्रॉम 6 days a week and 8 hours a day, एक खातून कैसे काम कर सकती है एक पूरा 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 वीक और पूरा महीना, whole week and whole month, how she can work in the field. So we resolved this situation in the context that we started recruiting APIs, local APIs, who belongs to the same mohalla, and with the consent of the community partnership and the community ownership. So we recruited this lady as API, and she belongs to the same mohalla and same street. All the community knows very well. Women are know very well to this lady. We just trained these ladies to work in their street mohalla about family planning and reproductive health and delivery of knowledge transfer and basic contraceptives. Condom and pills. The second job was her to refer the clients from identified client to near this networking that we already developed for this area. नेटवर्क हम एक छोटा सा डेवलप कर देते हैं जिसमें LHV, midwife and similar hospital जो एरिया के अंदर मौजूद हैं उनको पिच करने के लिए, ताकि वो उनको सर्विसेज कॉन्डोम और इंजेक्शन और उसके अलावा IUD, इम्प्लांट, अदर सर्विसेज जो एक नॉन क्वालिफाइड बंदी नहीं दे सकती, जो API नहीं प्रोवाइड कर सकती, वो उनको वहां से सर्विस प्रोवाइड कर दे. तो हमने इसको सबसे पहले तो कॉन्टेक्चुअलाइज किया. शी इज द लोकल लेडी and she work in the same mohalla, and she has no restrictions to work from morning 9 a.m. to 5 p.m. evening. She can work any time in a day in her street, in her mohalla, so that it become convenient for her and for her family. And with the same time, she can also work with her family and with their children, so that she can get convenience to work with us. So this is the basic root cause that we addressed in this program. And the second, we trained this lady for digitalization. As you know that this is the period of digitalization. We trained them to collect data on digital gadgets which were installed in her mobile. वो हर घर में जाती है, वहां से मदर्स ऑफ रिप्रोडक्टिव एज जो मैरिड खवातीन हैं उनका डाटा लेती है और उनको उस गैजेट्स में अपलोड कर देती है. और फिर हमने उसको बड़ा ही क्रिटिकली देखा कि हम इसकी मॉनिटरिंग कास्ट, हाउ वी कैन रिड्यूस द मॉनिटरिंग कास्ट ऑफ दिस प्रोजेक्ट। नॉर्मली होता ये है कि हर प्रोजेक्ट में एक मॉनिटरिंग ऑफिसर होता है जो हर स्टाफ के पीछे जाता है। इवन के गवर्नमेंट के सिस्टम में भी there are a lot of monitoring officers who are going back to lady health workers, उससे कास्ट बहुत ज्यादा इंक्रीज होती है। तो हमने उसको रिड्यूस करने के लिए डिजिटल इंटरवेंशंस की, और डिजिटल इंटरवेंशन में हमने उसको डेस्क रिव्यू पे लेके आए कि उसके पास जो गैजेट्स है उसको हम ट्रैक कैसे कर सकते हैं। वी ट्रैक दिस आरपी इन द फील्ड थ्रू digital mapping, and also we get the area estimates through Google mapping and heat mapping, so that हम identify कर सकें कि किस एरिया में population junk कितना है, और फिर उसकी अवेलेबिलिटी वहां पे कितनी होगी, और डेली बेसिस पे वो कितने घरों को विजिट कर सकती है। तो हमने वो सारी टेक्नोलॉजी इनबिल्ट की, and the RP is now responsible to work in a day, 4 to 5 hours a day, and she is responsible to visit 4 to 5 households for family planning, reproductive health, and transfer of knowledge, and collecting the information, and referring the clients to nearly RHC, BHU, and even lady health worker clinics, and any doctor clinic, so that the client can get service from there. So this is the basic mechanism. First thing is the contextualization, and the second one is the integration of the digitalization and the technology. And at the third stage, when we did this work with almost 136,000 families, and in the period of 2 years. And we saw that she outreached 99% to Mabras who received services from this API through the API service, and we almost increased in CPR that was initially calculated by the government of Punjab, that 33%, and after the period of the 2 years, they reported that in that area where API worked successfully, and I would like to explain here that this area was totally blank area. There was no lady health worker, and no government services are available in that area. So they calculated and reported that in this area the contraceptive CPR level is almost 41%. So we continue this work with these APIs, and independently APIs work in their mohalla as a sustainability plan, and because they are living in the same mohalla and the same streets, so we got in touch with them for the 2 years. And recently, in 2025, we again calculated the CPR, and again calculated the figures from that area, and we found that tremendous results from this area. From 136,000 households, out of 136 households, we visited almost 4,500 households, and we saw that the CPR level is now 43%. 43% CPR level at this. So we scaled out this project to Karachi as well, in Orangi area, and we saw that these are the wonderful, and we also recommending other agencies and the donors to replicate this strategy. Although we are not blaming that the lady health worker program is not good. Lady health worker program was very good, and it was good at that time when the lady health worker who was responsible only one job. Now, after the passage of the time, government pushed the burden of so many jobs, so many tasks on this lady health worker, and due to that, she cannot perform so very well. Second thing,
So we have to also open questions.
Yeah.
Answer Naga.
Yeah.
Please.
Yeah.
It's a shortcut then, because we have to finish at 11.
Yeah. Thank you, sir. Thank you. The second thing is the distribution of the contraceptive, and we observe that when in any area the distribution of the contraceptive is discontinued, the CPR level comes down. And the third thing that I want to reiterate here that we are forcing maximum in Pakistan our strength on condom and pills. So as shown in the free sub presentation, that the condom and the pills also are not so much effective. So this is not a very good tool to reduce the population or to maintain or manage the population. So we recommend that IUCD and the long-term methods are more comfortable and more convenient for the management of population. And similarly, the last one point is that we observe that in the period when the contraceptive are not available in the field or in the market, mostly the clients are buying with their own. So we have to go on the option that instead of free of cost contraceptive, we have to move towards some little bit on cost contraceptions. Yeah, thank you.
Thank you very much. I think if we have these kind of programs in the country, elsewhere, I think things can start moving. A lot of issues raised by Dr. Farid could be, I think, resolved. Of course, we are grateful to Dr. Samin Siddiqui, who is here with us. A medical doctor with a PhD in public health, and he has a very relevant and important assignments he has held. Worked in, as I said, Ministry of Health. Then he moved to work for WHO for about 16 years with Emerald region, which is the Eastern Mediterranean region. Pakistan is from Pakistan onwards to Middle East and North Africa. And he's also served as a WHO representative in Lebanon and Iran, especially when he went to hear or he saw the situation in Iran. He has, besides, it's very rare that people who work for international organizations and the ministry, that they would also have time to write or publish. He has 150 publications on various countries, Pakistan and many other countries. Has been on the editorial board. I don't know where he got all the time to do all those things. And then finally he ended up, about 6-7 years ago at Aga Khan University. Perhaps I think the major or key institution in Pakistan. I said only, at least not only the two major institutions, universities in Pakistan. One in health sciences, which is Aga Khan University. He was professor and chairman of in the Department of Community Health Sciences. Still, he's a professor there, and he travels to Karachi quite often. So he is heading. Let's move to the questions. He is heading a very important thing that he's heading a task force on, or just developed a new health and population policy for the country. So, Dr. Samin, I would like to ask you about this new vision which you have come up with. I'm sure that you had extensive consultation with all the various people. It was because I know when you came to Karachi, I was part of it, and you consulted several people there. So please go ahead and tell us about it.
So thank you very much. I'm asked, so I'm supposed to speak in English? Before I get into that specific response, I think there's one point that I do want to mention, and that is we need to see why. Farid will put up a case, and I know we have not made progress in Pakistan in the area of family planning. And there's something that I'd like to sort of highlight, particularly for the population source. We need to look at the political economy of population in Pakistan. Why have we actually, and I think the issues around it are not technical. these are political issues. And unless we get a handle on those political issues, and I want to just highlight one political issue for your consideration, and then I'll get down to the work of the policy. So during the policy development process, we really had extensive consultations across the province with all provinces, including HAK, GB, with the development partners, with the government, with the private sector, and academia and so on and so forth, And I think it's important that we talk a bit about the NFC of the National Finance Award. And I want to spend a few minutes on that actually. Now, Pakistan has had a seventh NFC in the year 2011 following devolution. It's an important, if you don't know NFC, you should know. NFC is the forum where the resource distributions are decided in Pakistan. How are we going to distribute resources at the federal level and between provinces? And in the seventh NFC of Pakistan, and these days, if you read the newspaper, you'll find that there's some discussion going on for the eighth NFC, which is being led by the government, and the finance minister is very active, and there were some meetings held. Now, within the NFC, population gets a weightage of 82%. 82%. So the more population you have, the more money you get, actually. And so reducing population becomes, from a political standpoint, a disincentive for our policymakers, basically. And so when I was in the smaller provinces of Balochistan and Sindh, the minister was very open. He said, "Sir, Dr. Sameer, how can I reduce my population you're talking about? Because if I reduce that in Balochistan, my resources will be reduced, So what can I do? I have to, Similarly, the seats in the parliament are determined by the population. So these are very, very strong and important political issues that you need to get a handle. And we need to start talking about it from that perspective as well. And so now there is a discussion to reduce the population weightage, but I don't think it will fall. So I also looked at the Indian NFC award, and India does a much regular work. They do it every 5 years. I think it's about the 16th or 17th NFC award. And I want to bring to your attention that the population weightage in the Indian NFC award is 15%, 15%, compared to 82% here. The biggest factor that gets resources in the Indian NFC award system is the GDP of the state compared the distance of the GDP from the state from the national GDP. So the greater the distance, the higher the resource they get. So what I want to bring is that it's really a political issue as much as it is a technical, cultural, and other financing issues. And we need to see it also from a political perspective. And somebody needs to look at the political economy of population in Pakistan if we need to start talking about it. Stakeholders, who are the ones, what are their powers, what are their positions, who are resisting this, who are not. And we need to talk about that. So we can do the epidemiology, and we can do the demography, and we can do all sorts of things, but we really need to get a handle on the political aspects of population. I think that work, I don't know how much that work is being done, but I don't see a lot of work being done in this area, of course. So I just thought I'll bring this particular point to the attention of this office crew. Now, on the point that you're talking about the policy development process, so that is correct. I had the privilege of leading a team of about 10 colleagues who we did the policy, and how did it all come about? So Pakistan currently has a national health vision document, which was announced in 2016, and it expires this year in 2025. It was a 10-year document. Some of you might have seen the document. You have seen it. So we were asked to review the level of implementation of the previous policy document, the national vision as it is called. And one of our big recommendations, which was stating the obvious, was that clearly we need to have a new policy. But this time, the policy should not be a health policy. It should be a policy which should talk of health and population and nutrition together. And we should not leave it as only a health policy, So that's what we went on embarked with. And I'm not claiming that we covered everything in population, but we have certainly tried to focus on the family planning services. But we've also struck on the broader policy agenda that is born. Now, this is not my document. This is the document of the Ministry of Health. This is the document of the government. Our job really was to do the drafting of it and the development of it, and of course, to prepare the document. And I just want to highlight 4 or 5 points in that, and then we can have more discussions. So what are we saying in that document? So the 5 or 6 areas that I want to highlight, which I think is, so I've talked about the NFC, we're talking about the NFC in that document. And we are saying that, we need to revisit and try and see how we can reduce the weightage to the population that currently it gets. The second point that we're also talking about is, and I think Farid mentioned it, family planning as a service to have a separate ministry, I think is just not, it's not working. It hasn't worked. It hasn't worked in any country. And so when I was in Egypt and I lived there for many years, their ministry is called the Ministry of Health and Population. Wizara al-Siha Sukan. Sukan is population in Arabic. So that's population that they have. Same is the case with many other countries where there are health and population come together basically. So we need that. I think some movement has happened in the provinces. Punjab has merged it. Other provinces are moving in that direction. But I think we need to have family. So it's not a problem of population. The health department, which has an elaborate network in the country, has not been able to deliver on family planning because there is a vertical program, and that's why I think it's so important that we bring this together and we start implementing. Not to underestimate the importance of the private sector. I think that both the for-profit private sector and the non-profit private sector has to do this. But the responsibility of financing primary care and population planning remains with the government. So I think it is a government responsibility to finance, and that also the governments are not doing. And I think that's a major gap, that the government should to put in more money, which means if contraceptive supplies, commodities are not available, then you will never be able to reach the numbers that we would like to. I don't know how many of you, so can you raise your hand? How many of you visit or work in the district, at the district level in Pakistan? Yeah, so there are quite a few hands that I see. So I have big programs in the districts, and we work particularly in Sindh, but in many districts. And I want to tell you that the population welfare department is pretty non-functional. I mean, health is poor, but it is functional. But when I visit the 2 or 3 clinics or their centers, as they are called, they're pretty. The staff is not there. The contraceptives are not there. I don't see how we could ever make these functional. So the reach is not there. So I think there are major gaps at the delivery level, and unless those are, so we are strongly proposing that these should be, Then I think we are also talking about a couple of more things. Some countries like Turkey, like I think Bangladesh, if I'm not wrong, have had strong legislation, and Iran as well, strong legislation in support of family planning. I don't know how strong how strong is that legislation in family planning? None. You see, there you see. So I'm not a family planning expert, but I worked in health for decades.
Is this issue in
Right.
Iran?
Yeah. So unless we do these things, and then lastly, we also need to talk of the broader development agenda. So women's literacy, women's empowerment, women's labor force participation, these things are key. Even in health, when I see women medical doctors graduate and they're not working for all sorts of cultural reasons. So unless we give women that space to be able to work and be active members of the labor force, I don't see how we could make a difference. And I think that's a major gap in our country compared to some of the other South Asian countries, including Pakistan, India, Bangladesh, Sri Lanka, and Nepal, where I have actually had some experience of working. So these are some of the areas that we would like, that we've brought into the policy, and we think that if the government will be announcing it actually on the 16th of December. The minister will be announcing the national health policy, and I hope he will include all of these things. Then I think, and if he can walk the talk and implement all this in future, in the next 5 to 10 years, perhaps we might be able to make a difference to the population outcomes in this country. So I'm going to stop here.
Yeah, thank you. I have some comments. Shall I do it now?
Yeah.
Because it's related to what you're saying. When Benazir's government came in, Mohtarma Benazir Bhutto, Shaheed, but that's the official designation of hers. When it came in power in early 1990s, they formed a committee or a steering committee for new national health policy. And I was a member of that committee on behalf of Pakistan University. And we presented our own work on the what we call community health workers, where we had several of them in different squad settlements of Karachi and Sindh and in northern area of Pakistan. And we were able to convince the chair that they have, start a program, and they started Lady Health Workers program. We are very good in making policies, but don't implement. The change of the government, the Lady Health Workers program was completely gone. They're doing something else. And one of the evaluations suggested that 50% of them, they're political appointees, they don't go to work there, somebody is made or whatever. So that's a evaluation done by that council, by the way. That's documented. So that is an issue that, okay, will this policy be implemented after the change of the government? I don't know. Secondly, as I mentioned that in my presentation, in the meeting, the summit, I don't know why they call it summit. Summit means some high-ups there. The prime minister couldn't come, and nobody on top echelon of the political, the government came there. Some of them did. But the former chairman of the Senate was there, and I asked them, then why don't you have a legislation? Because Iran did it, and many other countries did it, Turkey and others, and they don't have any answer. Nobody talks about population as an issue in the assembly. They talk about everything else, raising their own salary, for example. So that's a very, very important issue which needs to be pursued. I know that the present minister is very keen, and so is the planning minister, but unfortunately, they couldn't make it to our conference. But that is the important thing, that is it going to be implemented? Well, I'll move on to the next question.
Can I just make?
Yes.
So on the Lady Health Workers program, I just want to make a clarification. So I think the name when it was established in 1993, and yes, I was still there at that, it was called the Lady Health Workers Program for Family Planning and Primary Health Care. That was the name of the program. So it's not that with the change of governments, the program sort of fell through. It is over the years, FP kind of started disappearing. And then primary healthcare and a lot of other things, polio and immunization and this and that got included. And family planning sort of got on the margins. And I think that is what happened with that program. And that is why, otherwise that program started very well with the young girls actually walking with contraceptives to every household, And initially it had some very good impact. Unfortunately, like many things, we were not able to sustain that. But I just want to bring that up.
Yeah, not talking about even yesterday I presented the figures that CPR went up from 12% in 1991 to about by the year 2000 it was 20%. So yes, it did work. Now the thing is, that's what I'm saying, that it all depends on implementation. The Marshall, not the General Musharraf's regime, they didn't do anything. A lot of them kept on coming up with new policy after one another. And so that last one, they did population policy in 2010, and then it was devolved. Each of the provinces have their own population policy. Dr. Tausif did it for Sindh population policy in 2016. And when I came back in 2017, so UNFPA hired me as a consultant to do implementation of the policy. I wrote a report. I went to districts. I saw the same thing what Dr. Salim is saying. Completely non-functional, the district programs at the district level. I'm not talking about Sindh. And I wrote a report, no implementation by the ministry. They just kept it, as it happens. So implementation is the problem, and I'm glad that Dr. Samin is sitting here and with the ministry, and he is advising them, and he will be able to pursue implementation, have the legislation. Let's move on to other very important issue, and the issue is that what is happening, how they have done it. in other countries. Dr. Samin has a very wide and rich experience working in various countries, and my favorite topic is also there. Muslim countries. We talk about, oh, Islam is a problem, but I think it's also a solution. If we look at the different, a lot of us have done research, and one of them also that there's no, as I say, Maulana Sahib कहते हैं, ममानत बिल्कुल नहीं है family planning की, neither in Quran or in any hadith. So how they have done it in countries like Iran, completely shifting from pro-natalist to anti-natalist policy under Ayatollah Khomeini. And of course, Egypt and other countries, Jordan, Jordan. When I was doing my PhD thesis, in late 70s, we had WFS, World Fertility Survey. Jordan's total fertility rate was 7 in 1970s, and now they're like 2.6.
Saudi Arabia.
Saudi Arabia, no, they don't have any family planning program. But Egypt, in 2017, Egypt had a total fertility rate of 2.6, same as Pakistan. In 5 years, it was 1.8. So can you just give us examples how they have done it?
Well, first of all, I have not worked with, I'm not a family planning.
But they have integrated.
So let me give you my take on that. So I worked a lot in health. I do in many countries that I do agree with. And I've served as a WHO representative in Iran, so I do know a bit about that. So I think in Iran particularly, since you talked about it, I think despite the fact that it's a religious regime, they have been able to mobilize their Maulvis or their religious leaders who have given fatwas in support of family planning. And I think that has made a difference, because when you get the support of the religious leaders and who make these statements, I think it makes a big difference to how people perceive it. And so that's one factor. The other factor is that the Community Health Worker Program of Iran is quite an amazing program. It's been there for 50 years. We've tried to model our program. It's called the Behwars. The community health worker there is called the Behwars. And they really are extremely empowered, very well trained, have all the supplies. And so they have made a huge, huge difference. But if you live in Iran, you will see more women on jobs on the streets of Tehran. You will see women active. You will see women in the workforce. You will see so much of that. And I think that cannot be underestimated, which is really not the case in our country, unfortunately, in every sector, not just in health and education, but in every sector. So there is a far greater women's engagement, empowerment, literacy, and Iran is a high level of literacy. So there are all sorts of these factors which have come together to help. And Iran's, I think, the prevalence rate somewhere is around 65-70%. And so there you go. So it's around that. So that's why I think in Iran. But other countries also, I think legislation has been an important thing, as we mentioned, in Turkey and also in Iran. Similarly, in Jordan, I think the level of literacy in women. Jordan is a very good primary healthcare system, by the way, and they have a good reach. And again, the level of literacy have gone up in the last few years quite a lot. So I think they have made on the as I mentioned about Egypt, and there's another Nepal also, not part of EMRO. Their Ministry of Health and Population, and also in Bangladesh, it's called Health and Family Welfare. And India, it's also called Health and Family Welfare. And in Nepal, it's Health and Population. And in Egypt, it's also Health and Population. So they have already merged and integrated it. And family planning is not seen as a separate thing. It's very much part of a health service, And I think that is one of the ways that we need to move forward, I think lastly on the demand side, so one is from the supply side, and that is, how you provide contraceptives, what network, who delivers services, and so on and so forth. But from the demand side, it's as important is because unless you create the demand through social marketing, you will not be able to make that kind of a difference, And I think that demand creation has been through campaigns, through media, and through religious leaders has been quite effective in many Muslim countries. And not to forget Indonesia, another country where I think the family planning program is very, very effective. So I think it's not that Muslim countries cannot, Muslim countries have done it. and they can do it. And I believe Pakistan can learn a lot from the experience of these countries. Saudi Arabia, you talked about, may not have a program, but if you look at their 2030 agenda of now, family planning is part of that. And if you look at their TFR, it is 2.4 or 2.5. So it's not really, no, it's less now. I just. 2.3, it's 2.3. So you can already see without a very active program, even there, it's 2.3 is there, so you can always, it's not just from the supply side, it's also when people demand and there's level of awareness, you can make a difference to your levels of population growth. So, so we have a lot to learn, and I hope that we will learn a few lessons and make a difference to our social and economic development in this country.
Yeah, and Pakistan.
Just very quickly, sorry.
Yeah.
Okay, so.
You have to finish and then we can come for question and answer. I have one more question for them.
Oh, got
Yeah.
I just wanted to add one thing that first of all, that in Saudi Arabia, the TFR was 2.7 in 2007. Not like new thing. Okay, the second thing is about which we have not talked about is that family planning always follows education.
Right.
It's never the other way around. And this is one.
Yeah, they have educated women, so that's they're big universities. I've also had spent a year in Riyadh, and I saw that myself. Dr. Farid is also spent several years in Saudi Arabia, so he knows the country very well. It's the issue is that we have problems in the country. The DHS of 2017-18. If we look at the 5 quartiles they have, the lowest quartile, the poorest women in Pakistan, they have in 2017-18 a TFR of 5. And the highest quartile, in which all of us belong, have all the things in the household, including car and air conditioner or whatever. Their TFR is 2.8 watts. So they are also not, they have not reached replacement level, so it's close to 3, education doesn't, and they are highly educated, all of them are educated.
education alone.
Education alone doesn't, the services are very important. So yeah,
Yeah.
so may I ask him last question? And then you will get a chair, you're there. I'm sorry for that. So because we have to finish also, because I have a very important question asking from him. Not important. Dr. Samin, you as a chairman of the Department of Community Health Sciences, you implemented health program in various.
I'm implementing one.
I'm implementing one, and I'm sure that part of family planning is part of it. How do you see that, how successful those programs have been? We heard from after Amir Khan Foundation. How do you see the potentials of that and upscaling?
So I'll try and be brief because I think we need to have more. So, basically your question is how piloting a program, because universities pilot programs, they don't have large scale programs, So how do you move from piloting to scaling up, and is it realistic? And, yes, AKU and has done many in the past, including by you and Jack Bryant and other colleagues, where we have shown that these interventions work, but these are all pilot interventions. The problem is, if you really want to scale up, can you do it, and where does it work and where does it not work? So I think piloting, obviously, you often have an academic institution, they are far more motivated, their resources are available, often they get external financing from some donor or funder, because of the technical capacities are good. So we are quite often successful in pilot programs. Now, when it comes to scale up, if the government's political commitment is not there, if the capacity is not there, if the health system is weak, if the finances are not available, then scaling up does become a problem. However, I don't want to speak against, I think pilots are important. There is always a lesson in pilots. And if you leave a legacy as a result of the pilot, so some pilots is the donor funding is coming, and when the donor fund goes, the pilots collapse, and then you start with another project. But I think the pilot's main thing is that they should leave behind a legacy in terms of what the experiences have been, what makes it work, what doesn't work. So in our pilot that I'm doing in Tandua IR in a district in Sindh, which is implementing an essential package of services, we are trying to leave behind and continue, and with the government, we're working with them, a legacy of what are the lessons learned. We're leaving behind manuals, guidelines, standard operating procedures. Everything is trying to document so that if the government wants to replicate it, they will have some of this information, which is extremely well documented through these guidelines for potential replication. That doesn't guarantee replication, but at least it makes a case, or it makes the opportunity and the chances for replication better. I think I'm going to stop here.
Sure. Yeah, now we are open to question and answer. And the first question is coming from Professor Grace.
That's sort of an observation. You're always, many people talk about the importance of female education in general. Having taught a number of gender courses over several years, one of the things I find it's really essential to teach at the university level is what, at least one lecture on what I would consider in the US, 5th grade sex education. So my concern, and all of the kids always say, why didn't anybody ever tell us that? I think we make enormous assumptions about what people have learned about basic, how their own bodies function, how their partner's body functions, how the whole process works to get to population. And when we talk, a lot of women, I think, enter marriage with a very vague understanding of what the whole thing is about. And so my question is, and I know in Pakistan it's very delicate to talk about some of these things, but I think just basic education, not just general education, but basic education about our own bodies and how bodies work for both men and women. Because we talk about female education, but men need to learn about all this too. They're the decision makers in much of Pakistan. So I just like your thoughts on, is this part of your health process when you're, or how does that work?
Anybody else wants to respond?
Yeah, I think just quickly, Fareed, been teaching in medical colleges. And what do you think about the question which Professor Grace asked? Can you do that even in the medical
So I can
school?
start and maybe you can
Okay.
whichever.
Yeah,
Can you do that in what?
no, she's asking sex education.
So
Sex education, okay.
What are the opportunities?
Sex education and universities.
schools, not just schools.
Then even can you do it?
I think we can, right now, I think it's like, even this university, we can ask students if they are, any students there. I think that's probably not yet, we can
But you
maybe
should-
start some like, very carefully designed courses. But which are like not, which are within certain limits, but beyond that, I don't think so.
That's the mean.
Well, I always introduce it as this is a great gift from God and it can be used for good or ill.
So I'm not an expert in this area, but let me give you my thoughts. So it's my opinion and not based on any evidence. I think, it will vary. Obviously, if you do it in the very elite schools, it's possible. So you go to Karachi Grammar School or Lahore Grammar School, or the top of the line schools, and I think these things can happen. But today, if you want to try this in a public sector school, in a in a small city, it will be very difficult to do that. Having said that, I think the way that, but I think it should be done, there's no question about it, and I think we should. So this is a Muslim country, it's Islamic Republic, and people 97%. So I think one way to get into this, I think there are at least, I cannot count, but there are so many verses in the Quran about different aspects of sex, human body. For instance, the embryology is discussed in some ways. So if you use that as a starting point in this country, and build on that, I believe there could be a way for us to introduce that, because there is a lot of reference to these things about women's physiological development, their menstrual habits, the childbirth, the embryology, and so on and so forth. So I think that could be an entry point for us to do this. And I don't think people and the Maulvis and the Mullahs would object it if you refer, your starting point is from the verses of the Quran.
Yeah, please identify yourself.
Yes, I am Fazil Nabi Khan. I have been Director General in the Population Welfare Department. Sorry, I am Fazil Nabi and have been.
Just a question, please.
Yes, the question is to Dr. Samin. Sir, you said that population welfare is not working at the district level with the non-availability of contraceptives and service delivery outlets out of staff and closed. My question is that Population Welfare Department has been vacillating between federal and provincial governments. You know it. While health is there in its inception. You said that population department at the district level is not working. Health is not taking ownership of the planning. It is right. It is a fact before us. It is not taking. What do you suggest to make the services available at the district, taluka, village level? And why we couldn't make FP part of health service delivery?
But I think I'm speaking too much and I should be very brief. So first of all, I would not like to repeat, but as I have said, it requires a very serious political economy analysis of the population sector. And I will not get into that maybe when I made that comment, you may or may not have been there, but we need to look at all of this from a political, and there's a whole science, there's a whole political science to how you look at it from. There is a huge political agenda, and I did talk about it earlier on as well. But on the point about service delivery, which has happened is this my view is that since there is a separate population welfare department, health people think that it is not our job to give family planning services. कहते हैं हमारा तो काम ही नहीं है, वो तो population welfare department का काम है. अगर हम दे देते हैं services तो हमारी अच्छी बात है, लेकिन हमारा primary response. So unless the Department of Health, which is a much so in the district that I work, there are 55 health facilities. And there are 3 population welfare facilities.
Yes.
Now you tell me, how can population welfare deliver services in that district, even if they are functional, and by and large, they're not functional.
Yes.
So health has to be made responsible and they have to be given the task to deliver services. At the moment, they don't feel obliged to be unresponsible. They give services for other things, but they don't feel obliged to that. And that change has to come about.
Okay, I have one question. I'm Sumit Ashok from NUST. Sir, I have one question from Dr. Salim. Sir, thank you for highlighting how population reduction reduces the political incentives and how the new policy links to population health and nutrition. But you said the legislation policy. My question is, what type of legislation you want to improve the population, welfare, number one. And the second, in the history we have witnessed one child policy in China, right? So that is still inconclusive. For instance, when it comes to the natural science diagnostic tools, they have very decent diagnostic tools and they go to the problem where the actually problem has. But when it comes to the social science, you don't think that we have the problem with our diagnostic tools, number one. And the second one, we are always in hurry. For instance, rather the fact is, or what is the descriptive of that, we directly jump into the what ought to be, what should be. Thank you, sir.
Somebody else wants to answer this question?
The legislation,
So I'm not Sure, I fully understood your question. मैं पहला जो part of the
सर
legislation
आप कह रहे थे कि पाकिस्तान में अब तक कोई लेजिस्लेशन
हाँ उसका सवाल उसका जवाब दे दीजिए जो दूसरा part था डायग्नोस्टिक का वो मैं ज्यादा शक है नहीं तो
I just say, I answer the.
So I think we do not need to be as radical as what China has been doing in terms of having a one-child policy. We need to have a realistic policy for this country. But if you read the newspaper, as of 2 days ago, the Sindh government is legislating, for instance, premarital counseling. Actually, like legislation on ESP. It's in the newspapers, and you can also talk. And so they're talking of all sorts of things, including educating women and so on and so forth, and the couples, and screening for things, and so on and so forth. So there could be all sorts of legislations. I would certainly go for one legislation about informing, population, making them more aware, do premarital counseling and inform. But there could be other forms of legislation also, which ensure, for instance, you can ensure through legislation that every health and other facility must be provider of family planning services. For that, you need legislation, you need regulation, and then you need ways to enforce the regulation. Without enforcement of a regulation, you will not have any impact, So there could be different kinds of regulation that you could do to be able to make family planning services far more reachable, to the population.
Dr. Farid, you have an answer.
एक second, I think one of the reasons reservations don't work is because they don't have teeth. और उसकी जो नियत होती है वो भी होती है कि पॉलिटिकल गिमिक बनानी है। ये सेम का चौथा या तीसरा मेरा ख्याल है जो बिल आया है जिसमें उन्होंने लेजिस्लेशन की है इन द फील्ड ऑफ रिप्रोडक्टिव हेल्थ। और आप कहें कि जी कोई खातून को अगर उसका शोहर एंटीनेटल केयर के लिए नहीं ले जाएगा तो उसके खिलाफ ये होगा, कैसे होगा भाई? ये पाकिस्तान।
Dr. Adnan, very interestingly, he has been at the forefront in a very interesting, special issue of JPMA, Journal of Pakistan Medical Association. A lot of things written about how family planning programs should proceed further. It has been like 2021, so 5 years almost. But I don't think anybody, none of the policymakers ever got to read these reports. They're very nice, beautiful papers, research papers. So Dr. Adnan, you have a question here.
Okay, so I thank you, Dr. Mehta. Basically, I have a logical inconsistency to point out, which I think nobody has actually talked about. Last week's summit, this week's this conference. I mean, just look at it. Dr. Farid actually said 44% of users got their services, but that's actually users. That's a lot of people ligation people from. If you look at the foot traffic says about 34% of foot traffic for family planning is in the public sector. In 2017, that was 1.6 million users. That's 4.7% of all married women of reproductive age got their service from a government facility. Now, we got interested and said, is Pakistan an outlier? And it turns out only about 19% of primary healthcare outpatient services are availed in a government facility in Pakistan. So is Pakistan an outlier? And it turns out that we are looking at now 172 countries across the world. And if you're an LMIC, which is large enough, let's say about 25 million or more population, more than half of your services are going to be in the private sector. So there's a reason why governments in LMIC don't function. There's multiple reasons. Governance is one of them. But the point is, be as it may, that is what it is. We have been focusing entirely too much on what the government does or does not do. We've been wasting a lot of time and resources in thinking on that and ignoring what happened. So since 2017, last DHS to now, there's a lot of stuff that's happened. None of that is being captured. It's not being captured in national surveys, but there's studies that are showing have been looked at that. I mean, after Amir Khan Foundation, 1.1 million people reached in a 2-year period. And 5 years after the first phase of intervention was stopped, the CPR dropped only 2 percentage points from 45 to 43%. But what happened was there were far more in the follow-up, there are only 15% condom and pill users. There are 75% users that are using injections and IUCD. Those are they're paying for those. And these are not trivial, these are 40,000 women that are, so thinking private sector, government sector is going to do what they're going to do. They're not going to do what they're not going to do. But they're also not going to do one point, they also have a regulatory negative role. Right now, one of the most promising technologies is DMPA-SC, subcutaneous. A lot of it is sitting in the board, the government is not allowing Pfizer to pick it up. It could be a game changer, we would actually in next 5 years be saying, oh, we have like 55% CPR. Most women are actually using either injection or IUCDs, but that's not happening because it's sitting out there and
Yeah.
I can't buy it,
Yes,
it's got to run a program.
So, this question, I think a very valid question. I just, if I may answer another, my panelists would like to. Nothing has changed since 2017-18. The two surveys which have come out, one by Government of Punjab, which is mixed, done just last year. I saw the report. The contraceptive prevalence rate in Punjab is still 35%. Okay. So I understand the report is, huh?
It's not weighted.
No, it doesn't matter. It has not changed. Okay. So whether the private sector is doing something, maybe they have not given yet the methods mixed or whatever. In Sindh, the situation is even worse. The Population Council has conducted a survey, and which the Department of Population Welfare is sitting on it. They have not released it, but I have seen the report. It's 21% in Sindh, the modern method. So nothing has changed. In 1992, I believe, or whenever the government change was there, at Aga Khan University, we had a big conference, call it Role of Research Universities in Implementing Population Health and Education Program in Pakistan. Prime Minister Benazir Bhutto was the chief guest, and I made a presentation in that, and we talked about please, for us, slide joy. And the things have not been, and then it's going on the same thing. Nothing has changed. The policy level, nothing. I'm not trying to say that, okay, this is something very important, but this is 1990s. Okay, they did something, the government of the day, but nothing. This later in 2003, when USA came back to Pakistan, they wanted to say how we can improve the program. And they gave a lot of money to Pakistan during President Musharraf's regime. It's published in the Oxford University Press publication, and nothing has changed since then, 2003, which is in written form. So nobody cares in Pakistan, the policymakers. And I'd like to end up with one thing. That is education, health, and family planning. People want to go to private sector in education. We are sitting in it's a private university basically, although heavily funded by the government, but it's a private university. The structure is very different. Aga Khan is a private university. Everybody wants to go to the first priority of these students is go there. So private schools, even in Kachi Abadi, there are private schools where one people. Healthcare, I don't know. The last time I remember, it was 85% of people, when they get sick, they go to the private sector. Family planning, it has to be taken off from the government. They can just make the policy, do the monitoring, and give it to public-private partnership. Or that's the way it's going to work. Otherwise, it's not going to work. Bangladesh did it that way, by the way. We talk a lot about Bangladesh. BRAC and Grameen Bank, they played key role there. The private sector played key role there. So unless until we get out of the clutches of the bureaucracy, it's not going to work. Your program, Aga Khan's program, Akhtar Hamid Khan's program, our foundation's program, and many others, they do it at a very small scale level. They cannot go nationally. Something has to be done at the national level. And when that is done, the bureaucrats don't want to do it. They don't want to leave the program. There's a lot of lucrative assignments, travels, and whatever. Unless until, they could go and work for this public-private partnership. Sindh has implemented in the health program, public-private partnership in healthcare. They're doing very good job. I have an opportunity to evaluate it in some of the districts of Sindh. They're doing a very good job there. So if that's the situation comes in Pakistan, it will work. I think we have last question before we move to that chair. Yeah.
Thank you. I'm Meera Karan from Population Council. So, sir, there are two comments. One on the 22% you just quoted that Population Council released this report. I just want to make a clarification that Population Council is not standing by this CPR. We, along with PWD Sindh, we asked Planning Commission to hold those results. The reason is that we completely we have confidence that the data being collected on this family planning section is not up to the mark in terms of quality. That is why we say that these numbers or these percentages should not be quoted anywhere. So this is one clarification I want to make. And we are holding these results back, and on other indicators we are releasing the report soon. So that's one comment. And other thing I wanted to make, that I totally agree with Dr. Sameer that only what I understand personally, that it's a political commitment issue, because when we see that the unmet need is 17%, if unmet need is out there, if we are able to meet only this 17% people need, at least we can improve our CPR. So that's only lack of political commitment and supply side issues. We have been talking about all these factors, but we are forgetting that there's a quality of services is big. If the higher ups decide something and they make a plan and they instruct down to the district level that this sort of quality of services should be provided. But who is going to make it counter check that it is really happening? So I think when we talk about it, we should be talking about quality of care.
Definitely. One of the bullet points, members quality of it was it's 2003 Kivu presentation. Anyways, as Dr. Farid has already talked about, who is using contraceptives? Women who already have 5 children. Okay, so that won't matter, it will matter that unless until they reach out, as in Bangladesh, 20%, the CPR is 20% among those women who have no children. Here it's 0, by the way, in 2017 DHS. So unless until we try to have a proper mix of the contraceptives, it's not going to work. Please, so the question, Putin, no comment, please.
So my question, I'm doing MS Economics. My name is Farstina and I'm from Balochistan. So my question is, why was sun preference not addressed as a contributing factor in the discussion on population growth? As क्योंकि मैं बलूचिस्तान से हूँ, वहाँ पर सन को बहुत ज़्यादा प्रेफर किया जाता है और उसके चक्कर में 10 बेटियां पैदा हो जाती हैं। मेरी 10 फूफाएं हैं और उनके अक्सर मेरी फूफाओं की 10 बेटियां हैं बेटे के चक्कर में। तो मैं ये पूछना चाह रही थी अवेयरनेस प्रोग्राम में सर आपसे खासकर कि आप इस चीज को डिस्ट्रिक्ट लेवल पे क्यों नहीं अवेयर करते कि आप बेटियों को एजुकेट करना कि आप बेटों के चक्कर में बहुत सारे पॉपुलेशन को ग्रोथ करे. थैंक यू सो मच.
Excellent point. Thank you.
That is an interesting thing, but ये जो आपकी बात है ना बलूचिस्तान में एक और चीज है. अगर पहली बेटी पैदा हो तो 5 साल वेट करो, अगला बच्चा बेटा होगा. I think we should promote this.
सर इसी चक्कर में सर अगर मैं कहूँगी अगर आप अवेयरनेस प्रोग्राम जैसे सर ने कहा था हम लेडी हेडक्वार्टर के साथ किसी आपी को बेचते हैं तो सर अगर वहां पे आप किसी आपी को ये भी अवेयर करें कि वो ये बताए कि सर आजकल इतना ज्यादा प्रेफर ना करें क्योंकि दुनिया ने तरक्की कर रही है. तो इस वजह से अगर आप थोड़ा सा उनको ये अवेयर भी कर दे कि लोगों को ये बताएं कि
I think you're right, and Dr. Farid is also from Balochistan, by the way. It's not the women, it's the men. It's the men who are the problem. And then there's a lot of things written, very good research करता हूँ. और एक USA ने किया हुआ था 2015 का family planning through the lens of men. Men are the ones, the main culprits, by the way. Sorry to say that I belong to the same community. So I think we are about to, we have exceeded the time. Dr. Grace, if you have any comments, and I'm sure you have lots of comments.
So I was just mentioning to Dr. Samin that we did have an excellent presentation yesterday. From a young woman from Balochistan about the national award, so I hope you all can get together. This has been a wonderful, distinguished panel. And we've all been fortunate to hear it, and you've been a wonderful, distinguished audience, so we're, you know, I think, one thing you said, Dr. Bennett, that you wouldn't be here in 2047. I have great faith you will be, right? But you did a wonderful presentation of causes of this issue, and you presented some solutions, which I think is what we're all looking for. In your presentation, Dr. Khan, I think you pointed out how important it is to train basic workers. I mean, one of the things I'm still trying to process myself is how is it possible to give postpartum care and not talk about family planning? I mean, I don't get it. But anyway, but what you're talking about with the training and the importance of community participation and having people feel they have some ownership of this issue and this program. And also your findings that long-term contraceptive use was or long-term methods were the most usable and used. Dr. Samin, you were a wonderful source of information for all of us. You talked to everybody about the importance of the NFC award. You talked about the importance of bringing together family planning and health. You know, one of the other ways that it's possible to do this is to make family planning centers do health. So that's the other piece of it that might help, and the other way of looking at it. To make local people, you also emphasize the importance of local and the possibility of having strong legislation to support this whole process. And most of all, that this is not a singular issue, that it's deeply interconnected with all sorts of long-term development issues. And there needs to be a long-term plan that addresses many of these issues, not just family planning. So I thank you all very much for participating, and I thank you. We're a wonderful audience. Thank you very much.
As a moderator, I would like to thank all my panelists sitting here. I'm sorry, I shouldn't I spoke forward also as a moderator, but this is something very close to my heart. Something should be done. Doctor, I'm sure that Farid will be there, but I don't want to see 500 million people in 2047. And so that is something which is very, very questionable. We are not going to, we are just going to, as Dr. Farid already said, I also said in the summit of Dawn that time to talk, it's over, it's time to act. And I'm glad that Dr. Samin Siddiqui has come up with a new policy, and I'm sure that he is going to pursue the government to implement it.
It's not my policy, I'm just drafting the policy
Yeah.
for the company. It's a
But-
government policy.
Government policy, but you are drafting it, but you also
Yeah.
draft them to implement it.
That's-
Thank you very much again.
Thank you.
Dr. Atma, you have next.
I would like to request Dr. Grace to give the team as a vote of thanks to all the presenters and panelists.
Okay, but you.
Next, I would request Dr. Sri. A small token of thanks.
ये सारा व्यू किस पे लाइव
Now I would request Mr. Imran to come forward and accept a small token of thanks.
Thank you.
Now I would request. Now I would request Dr. Grace to present the shield to Dr. Mehta. President of. Now I would request Dr. Mehta to present the shield to Dr. Grace. Okay. That's your shield. And now I would request Dr. Grace to please give a shield to our very own Dr. Aisha Sheraz. And thank you so much to all the participants. Now I would like to invite you for a cup of tea. And we will assemble again in 15 minutes for the next session. Thank you so much.